what Charlie said about the importance of genetics, I will try to move on two concepts. One is more general concept. Why is important personal medicine? Why is something that belongs to all of us, and why the science of personal medicine could improve psychiatry? This is the first point. And the second will go on what we know in anxiety disorders. So it is really something new. I say no. We are all doing personal psychiatry. We are all personal psychiatrists. And the reason why that we used to learn by our patients, by trial and errors. So we see patients, we make a hypothesis, diagnostic hypothesis, we give a drug, then we see the outcome. And we learn from the outcome if our prediction is correct. So we see many patients. The example is panic, because panic is my, you can say, core business somehow among anxiety disorders. And after many, many patients, what happens is this, that we build models in our mind. I'm sure that all of us are not prescribing drugs looking at the DSM criteria. You're using your model that you build with the time, with errors and proofs and true findings. And this is not a mistake. This is somehow, we can say, an expert judgment. And we suppose that after many, many years you become an expert, so you have some kind of good judgment of what you're doing. However, this is not enough in the new era, and especially it is something that could bring to the big trouble we find that when we talk with a colleague, we feel he's a good colleague, we feel he's very estimated, and he thinks completely different than what we think. So what happened? First of all, when we be like personal psychiatrists, so not psychiatry, talk about the person who's doing a personal kind of personal point of view in medicine. First of all, we see only what happened also in the computer, in the internet era. What you see is what you get. We cannot see genes. So we make our judgment only on what the patient tells us. We are blind to all the other things, all the other, we can say, not seeable world of them. So we cannot see genes, we cannot see heart function, we cannot see HPA axis function, and so on. So we are just taking a part of the information. But the second, I think, worst danger, and this is a part of our being human and feeling like God, is that while we are building our models, starting like young students, I remember when I was a young psychiatrist, we were collecting all the data carefully. It takes a long time. Now, often when the patient sits down, after 3 minutes, I already know what is the diagnosis. Okay? Maybe. I had also some proof that I made very big mistakes because I sent a patient, for example, for my team as an inpatient. They called me back and said, but maybe it was a little bit obsessive, don't you think? It was really a big obsessive part, but I forgot this. I just was looking what my prediction at that moment. So the worst things happen that when a patient fulfill our model, we're very happy to include them. When it's not in the model, we're skipping it out in a very simple way. If I believe strongly that a true panic patient is the one with cardiovascular disease and I'm convinced that they will respond to, let's say, paroxysm. If a patient comes with clear cardiovascular symptoms and do not respond to paroxysm, they say, it's not real panic, it's something different. So this is the reason why we create models, and these models become very strong and become not critical, not scientific. Become models that is more personal models, not scientific models. What is the dream from personal psychiatry? Is a science. First can move from the science of mean ideal patients, that is the one that most of the scientific papers show us. There are few patients with no comorbidity, with no heart disease, and so on. So it's not real patients, mean ideal patients. And we try to move to a science to real life patients. This could change things. The second point, that we can somehow become better personalized psychiatrists because we can overcome our personal biases. So we can move from that kind of bias that our model is the best in the world. And we can include hidden information on thinking, let's say genetic tests, genetics, markers, and so on. And we can open our minds to ideas of others. This is not trivial because we say that we open our mind to the ideas of the others, but I don't know how much we really do it. So in this way, personal psychiatry could help us in this view. An example, simple myself, I saw many pain patients, a huge number, and then have my ideas, but this is my personal ideas. I don't sure that they are right. You know? This is what is Perna personality psychiatry. Okay. So if you read here, this is I'm really convinced about this. If you ask me to write a book on how to treat many patients, I write these points, I develop these points. Okay. For example, here there is not a point. I'm convinced that there is not a link between bipolar disorder and panic disorder. But this is not what's present in the literature. So in this moment, I'm trying to change my mind. I'm trying to read the papers. I'm thinking maybe the other person is not so stupid. So maybe my colleagues are doing something better. But I need to open my mind and to look at science in a different way. Anyway, what is funny that these are not really demonstrated topics. No one. For example, I'm in my clinic, my team, we give sertraline all the time to patients who have vestibular symptoms. But we are so convinced that it's so, that is something that is like a rule in our behavior. But there is no evidence at all, and so on. Given this is the point. So, from a general point of view, I suggest to follow this line, especially because we'll become a better psychiatrist. It's not just another field of science, but it's a way to have a science really near to the real patients. This is what is the promise of personal psychiatry. Obviously, genetics is the first one because we have some evidence from other fields of medicine, oncology, that it works. It is impactful completely. Maybe not yet. There was a critical paper on the JAMA a few weeks ago, asking questions to the one who is supporting personal psychiatry, and they try to demonstrate that it is very nice, but do not have a real impact in clinical practice. This is not true. It has any impact. Also because for the single patients who have a single polymorphism who get better from a drug treatment, it was a single patient, but he was absolutely free from cancer. And they think this is good. You cannot make just a mess because it is not working. 1,000, 1 million patients is not a good idea. So I think this street is a good street. From genetics, what we can say about anxiety disorders. We recently, I and my colleague Daniele Caldirola made a small editorial on pharmacogenomics on what is the role in the treatment of panic disorder. Unfortunately, after a careful assessment, we have to say that today there is little research available. So only few persons studied in panic disorder genetics, pharmacogenetics, and the results are inconsistent. But there are some clues for the future. Another thing's nice, it was just a case report, but it's something anyway make us think that someone is trying to discuss the fact that you can use genetic testings already in clinical activity to change your point of view. This is a case report of a partially resistant patient with mixed depression and panic with a partial responder to venlafaxine. This clinician tried to make genetic analysis and fix the treatment based on the results, with having a complete result. This is a single case, so this is nothing from scientific point of view, but anyway, you can do it. I went to a lab near my clinic asking what was the cost for doing, for example, 5-HTTL-PR, so the polymorphism of the transporter, 15 euros. So now, if you want to test from a genetic point of view, some of the genes related to drug treatment, it is cheap. But I wasn't aware. I suppose he told me $300. No, he said, with $300 you can build all the different kinds of polymorphisms. So if you look at the cost of a single visit you do with the patients, with let's say a big name, it's not less than $300. So somehow you can have all the genetic testing, looking at what is the genes involved in treatment response with the same cost of a single outpatient visit. We have to keep this in mind. You have to check with your lab, and you can start at least to think about this. 10 years ago, we did the first study trying to see if there is a possibility to predict the response to paroxetine in panic disorder, looking at the polymorphisms of the promoter of the 5-HT gene, and we found that there was an effect, so we were able to predict this, mostly in females than in males. So we have to remember also that we used to give the same drugs to make the same predictions in males and females, but the brain of males and females are completely different. Often we forgot this key point. There are other studies, few studies. Really, I was impressed because we have just, let's say, 3-4 studies in panic disorder trying to put together the genetics and the prediction of treatment. And they used to, the data are showing that it might be, I say might be because the data are too scanty to have a definite conclusion, that the 5-HTTLPR genotype and the 5-HT1A could have a role in predicting the response. Another point, very important, is that if you look at the difference, we have to remember that the distribution of genes and the effect of genes are not the same in the whole human beings, but there are differences compared also to the different places in the world. It seems like the distribution and the effect of, for example, the 5-HTTLPR gene is different in the Western countries and the Eastern ones. Okay, and this is also happening for depression, for example. And in this case, in the core population, there is not this kind of effect. This is other studies anyway, just to show you that this field is somehow growing, even if we do have very few data. There is also they tried also to see if there is an effect of the COMT gene. That is another crucial point, trying to influence the effect of our drugs in the brain. And what is promising now, I don't know if it is a promise or not, but there is some studies showing that you can predict the response to CBT by the genotype. Okay, so this is very particular. What is particular? That the prediction is the contrary of what is happening with drugs. So if you have the short allele, you will be resistant to drug treatment. Okay, if you're homozygotic. This is the contrary for psychotherapy. This is particular because if you look even at the effect of drug treatment and psychotherapy in the brain, you will see that the part of the brain that is touched by these both different kind of treatments are different each other. Like they're not going on the same place. This is the reason maybe because they are somehow working together very well, because they're not going just on the same points. Data on psychotherapy is going also on the COMT. Okay, so there is an effect, even another important gene regulating neurotransmitter function, and even on the MAOA. Okay, so it seems like the most important genes regulating neurotransmitter do influence the response to CBT, and this is crucial because it seems very strange that you have to go from the genes to a psychological treatment, but it's not true. Just we are still moving on the Descartes' error, saying that the mind and the body are separated. So everybody thought that it's not so, but we reason in that way, and the genes are not reasoning in that way. Some curious thing that could be a way for the future. For example, CBT is able to change the methylation of the genes related to the serotonin transporter. And this is obviously very important because we move toward the epigenetic point of view. And this will be another street for the future. Oxytocin is another gene that have been somehow related and somehow linked to epigenetic changes in the treatment response. And you can see that it is not related only to panic, but also in other kind of treatment, other kind of anxiety disorders, such as generalized social disorder. You can see that SSRIs, serotonin transporter gene promoter, do predict the response to SSRIs. And here are the other ones. Anyway, the message I want to give you is that this is a field that is just growing now, but we have enough data to say that we cannot skip at this point. So the prediction of the response using genes seems to be very promising for the future in anxiety disorders. Even in CBT, for example, in this study, and this makes the difference between the different anxiety disorders, they're not exactly the same. We are not, personally, I am studying anxiety for many years, but I believe that they are completely different disorders. They're not the same. The system is not the same. Maybe overlapping somehow, but not the same. In this case, there is not an association. So the data are not currently coherent. Let's move on this. We have other data on this, even in JD. There is some data showing that if you have polymorphism in the serotonin transporter or serotonin receptor 2A, in this case you have different response. So there is some data showing that we can even try to predict, at least in some patients where we do feel that there is not a good response, we can even try to ask for a genetic profile and try to use this data to change our data, our treatment. Charlie talked about these important aspects, and this is another point that we have to keep in mind, that all the stress systems, the adrenal axis, the HPH axis, and so on, they are controlled by genes, and it might be that it is possible that some polymorphisms in that kind of genes could somehow interact with drug treatment. In this case, they show that a variant in the PACP gene was associated with a better treatment outcome in JD. So pharmacogenetics is not so advanced like in depression, but even anxiety disorder there is some move. Personal psychiatry is not only gene, okay? It's something that develops in all the different fields. One field is in neuroimaging, and there is some data showing that, for example, for CBT, that you can predict the treatment, the response to CBT, looking at the pattern of activation in the brain. In particular, it seems like those subjects who have a better function, the coupling between prefrontal cortex and, let's say, the limbic system, okay, the amygdala, they are the one who respond better. This is obvious, because if you do not have the street correct to influence the emotional brain, you're not able to change it. And these findings have been replicated, and there is this was another, I really am not aware what is a single subject anxiety treatment outcome prediction using this random forest model. I don't know it, but anyway, if you look at the study, they say still that there's a greater activation in the cortical limbic circuitry could predict better CBT response. This is happening also for generalized social anxiety disorders, so not only for panic, but you can have in different kinds of anxiety disorder. If you have a brain that is already prepared to react, this is similar to what you're saying with genetic. If you have a brain that is already prepared to react correctly to drugs, then the possibility of a better response is higher. Not only genes, not only brain imaging. We know that now it is the mainstream in psychiatry is doing genetics and brain imaging studies, maybe together, but we can go beyond this. We just look at a short preliminary study, what are the predictions of the efficacy of antipanic treatments. This is just the methods, the usual methods, and what we found that, for example, agoraphobia, that is supposed to be a predictor of response, is not a predictor. 9 studies out of 9 showed that it was not a predictor neither for drug or CBT response. Even the diagnosis of depression together with panic was not a predictor. Duration of illness was not a prediction. This was very strange, but anyway, in the obvious view, longer the disease, worse is the possibility of a good response. This is not true. Gender do not have a good effect, even age. There are some discordant data, and what makes me somehow impressed that you see that there is a depressive symptomatology and diagnosis of depression. Okay. In my view, depression is a disease. You cannot measure just symptoms. But anyway, there are several studies doing this. The only 3 strong predictors could be blood levels of antipanic drugs. This is the point. The early response to treatment and the personality disorder comorbidity. But this was just a preliminary view. We are going on trying to complete this kind of evaluation. Some years ago, let's say 13 years ago, we did a study where we showed that you can predict the response to drug antipanic agent looking at the decrease of carbon dioxide hypersensitivity after 1 week. So we give this marker in panic, where panic patients are hypersensitive. We measure this after 1 week of treatment before we have any clinical improvement, and we can predict the response after 1 month. This was a single study, then we was not able to go on because of, we can say, Italian rule system. In all the world, everybody was using carbon dioxide model to do research. In Italy, the minister told me that CO2 was an experimental drug. So I need to prepare the mixture like an experimental drug. It was not possible. No company did it. It was too expensive, so I had to give up this kind of stuff. This is a story that happens sometimes with the governments. Anyway, there is some strange data. For example, low PCO2 predict the response to CBT or ACT. Okay, so what is the meaning? We do not really, but we know that there is some data showing that you can even look at some biochemical parameters to predict the response. Even phosphate levels, I will show this because it's very particularly strange. The field of research is going on, could be a possible state marker in panic disorder. And in this case, this group suggests there could be a laboratory measure in clinical practice. Another point is that there is some evidence that you can predict a panic attack. Let's say. This group, a very good group from Stanford, showed that 45 minutes before an expected panic attack, you have you can say, the cardiorespiratory system become irregular. 45 minutes before. So obviously, you can even make a prediction of a panic attack if you are able to collect data. And I'm looking very carefully what is happening now in the industries, the smartwatch, where you can measure the parameters. The next step in the few months will be that they can measure respiratory rate. So they can measure heart rate variability and respiratory rate. You can measure with smartwatches. So you can imagine you can wear this and find an algorithm that could predict the presence. There is a company that already are selling a sort of smartwatch that is able to predict the epileptic seizure with algorithm specific of them. So the future will go also in this kind of device looking at physiological modulations. I'm concluding just saying that if we want to look at complexity, We need to change even some statistical way of looking at this. Machine learning, that is some supervised artificial neural networks, are systems able to reason like our brain. So they're trying, you can put some kind of information inside, this network will learn what is the rule, okay, and then you can then have some prediction. This can be the future. There is several projects funded now, and we are still also trying to understand how this works, and it could be a new way to see. We cannot use mean values to look at the complexity, to look at real patient. Last point, if you're interested, we built up a section in the World Psychiatric Association on psychiatry, okay? And we are having some, we can say, good hint for the future to grow up in this field. So if you're interested, you can just write, you can just visit it. You can even download a good number of papers free from here. There's also slides from Charlie, video from Charlie, so this is an opportunity to look for the future. Okay, thank you.